Hi, dear students. I'm Dr. Mushfig Orujov from the Department of Pathological Anatomy of Azerbaijan Medical University. Now I'm going to talk about the pathology of infectious diseases. The plan or content of the today lecture is the infectious diseases. So the introduction to the infectious diseases. Then we'll talk about the viral infections, rickettsia, the bacterial airborne infections, and finally about the bacterial intestinal infections. What's an infection? It is a complex process of interaction between pathogen and human body. Infection is composed of three factors: pathogen, host, and environment. There are commensalism and opportunistic infections. Infectious disease is a group of common diseases that are caused by different pathogens that possess an infectivity to form epidemic. And infectious disease is a threat to the health of people. Another definition that infectious disease that caused by an infectious agent such as the bacterium, virus, protozoan, or fungus that can be passed on to others. So the infection occurs when the infectious agent enters the body and begins to reproduce, may or may not lead to disease. What means the pathogen? This is infectious agent that causes disease. Host, we call that organism that infected by another organism. And the virulence, the relative ability of an agent to cause rapid and severe disease in a host. Robert Koch developed 4 criteria to demonstrate that a specific disease is caused by a particular agent. First, the specific agent must be associated with every case of the diseases. Second, the agent must be isolated from a disease host and grown in culture. 3. When the culture-grown agent is introduced into a healthy susceptible host, the agent must cause the same disease. And final, the same agent must again be isolated from the infected experimental host. One person can be transmitted to others. Causes of re-emerging of the problem of infectious diseases. First, loss of antibiotic effectiveness. Second, increased population density. Third, travel. That travels may bring back pathogens. Global warming. Then biological warfare or terrorist attacks. Sixth, new routes of transmission, such as the organ transplants, and the complacency and ignorance. That many possibly most people do not wash their hands after using the toilet. Main classes of infectious agents that include the bacteria, the gram-negative and gram-positive, viruses, with the DNA virus, RNA virus, and enveloped or non-enveloped, fungi that also may be disseminated or localized, and parasites, protozoa and helminths. Let me explain about some brief history of infectious diseases. The infectious agents have probably always caused disease in humans. Smallpox has been described in ancient Egyptian and Chinese writings and may have been responsible for more deaths than all other infectious diseases combined. There is evidence that malaria and the poliomyelitis have existed since ancient times. In the 14th century, the bubonic plague or Black Death killed about 20 million people in Europe alone. In the 20th century, the 1918 influenza may have killed up to 50 million people worldwide. Close to 32 million people have died of AIDS to date. So in our days, in 2020, the COVID-19 new coronavirus global pandemic kills people. Now let's discuss about the means of transmission. First, the contact. transmission that requires direct or indirect contact. The contact direct transmission occurs when the physical contact between an infected person and healthy person. Indirect contact transmission occurs when there is no direct human-to-human contact. Contact occurs from the reservoir to contaminated surfaces or objects, or to vectors such as the mosquitoes, flies, mice, fleas, ticks, rodent, or dogs. Second, food or water. Ingestion of contaminated food or water. Airborne way, inhalation of contaminated air. Then vector-borne, dependent on biology of vector as well as infectivity of organism. Perinatal transmission, similar to contact infection. However, the contact may occur in utero or during delivery. And sexual transmission by sexual intercourse. Here you see the illustrations regarding the transmission of the infectious diseases. Now in our days, you see the the pandemic of the coronavirus, that you have to wash your hands regularly with the soap and water. You have to cover your mouth and nose while sneezing or coughing. Factors influencing disease transmission. Here we see the three factors, that agents, environment, and the host. The agents include the infectivity, pathogenicity, virulence, immunogenicity, antigenic stability, and survival. The environmental factors include the weather, housing, geography, occupational setting, air quality, and food. And the host factors are the age, sex, genotype, behavior, nutritional status, and the health status. What does the pathogenicity mean? It means the ability of a microbiological agents to induce disease. And the pathogenicity of pathogen is related to invasiveness, virulence, number of the pathogen, and the mutations. Infectivity is the ability of agents to cause infection. Number of infections particles required. In person-to-person transmission, secondary attack rate is a measure of infectivity. Virulence is severity of the disease after infection occurs, measured by case fatality rate or the proportion of clinical cases that develop severe disease. What means the immunogenicity? It is the ability of organism to produce an immune response that provides protection against reinfection by the same or similar agent. Can be lifelong or for limited periods. Important information for development of vaccines. And we discussed about the immunity, that we have the non-specific immunity and the specific immunity. The non-specific immunity include the barrier action, such as the external barriers, the skin, mucosa, and ear secretion, and internal barriers, the placenta or blood-brain barrier, phagocytosis, and some humoral action complement, lysozyme, fibronectin, and cytokines. And the specific immunity that we'll discuss later in the general pathology course, that humoral immunity, immunoglobulins, and cell-mediated immunity. So about these barriers, you know that we repeat that the skin, mucous membrane, then cilia, coughing, and personal hygiene, they roles as the barriers for the defense against infection. And here you see the illustration of the HIV-1 virus on the surface of lymphocytes. The cases of the infectious diseases. The index, it means that the first case identified. Primary, the case that brings the infection into a population. Secondary, infected by a primary case. And tertiary, infected by a secondary case. The pathogenetic mechanism of the infectious diseases must be direct tissue invasion, such as the smallpox, the production of a toxin. Anthrax produce toxins that invade and destroy tissue. Immunologic enhancements or allergic reactions, persistent or latent infections, enhancement of host susceptibility to drugs, and immune suppression. There are some phases of the infectious diseases. First, incubation periods. That's time between infection and the appearance of signs and symptoms. Prodromal phase, mild, non-specific symptoms that signal onset of some diseases. Then clinical phase, a person experiences typical signs and symptoms of diseases. Decline phase, the subsidence of symptoms. And recovery phase, the symptoms have disappeared, tissues heal, and the body regains strength. And in this scheme, you see the periods of the disease. And here is the number of the pathogen particles, time, and the severity of symptoms that indicated in blue. So let's move on to classification of the infectious diseases. There are the viral diseases such as the influenza, HIV or AIDS, herpes viral infections, hepatitis, measles, mumps and rubella, poliomyelitis, and infectious mononucleosis. The bacterial diseases include the tuberculosis, scarlet fever, tetanus, gonorrhea, diphtheria, streptococcal infections, pneumonia, pertussis, bubonic plague, and there are many others. Then fungi. There are the organisms but without the chlorophyll. General life of dead organisms or dead material within a living organism. Some are single-cell organisms such as the yeast. Some are multi-cell organisms such as mushrooms. Many are extremely valuable. Yeast give us bread and alcohol. Mushrooms can cause disease by releasing enzymes that damage cells or by producing toxins. Some mushrooms produce the very deadly toxins. And now let's discuss about some terms used to classify infectious diseases. The duration of the period of illness can vary greatly depending on the pathogen, effectiveness of the human response in the host, and any medical treatment received. For an acute disease, pathologic changes occur over a relatively short time, hours, days, or a few weeks, and involve a rapid onset of disease conditions. For example, the influenza is considered an acute disease because the incubation period is approximately 1 to 2 days. Infected individuals can spread influenza to others for approximately 5 days after becoming ill. After approximately 1 week, individuals enter the period of decline. For a chronic disease, pathologic change can occur over a longer time spans. For example, months, years, or a lifetime. For example, the chronic gastritis is caused by the gram-negative bacterium Helicobacter pylori. Hepatitis B virus can cause a chronic infection in some patients who do not eliminate the virus after the acute illness. A chronic infection with hepatitis B virus is characterized by the continued production of infection virus for 6 months or longer after the acute infection, as measured by the presence of viral antigen in blood samples. In latent diseases, as opposite to chronic infections, the causal pathogen goes dormant for extended periods of time with no active replication. Examples of diseases that go into a latent state after the acute infection include herpes, chickenpox, zoster virus, and mononucleosis. Some infectious diseases are also communicable, meaning they are capable of being spread from person to person through either direct or indirect mechanisms. Some infectious communicable diseases are also considered contagious diseases, meaning they are easily spread from person to person, such as the COVID-19 coronavirus infections. Not all contagious diseases are equally so. The degree to which a disease is contagious usually depends on how the pathogen is transmitted. For example, measles is a highly contagious viral disease that can be transmitted when an infected person coughs or sneezes, and an uninfected person breathes in droplets containing the virus. Gonorrhea is not as contagious as measles because transmission of the pathogen requires close, intimate contact, usually sexual, between an infected person and an uninfected person. Common symptoms and signs of infectious diseases. First, the fever. There are 3 stages of the fever: effervescence, fastigium, and defervescence. Kinds of fever. There are some kinds of the fever, such as the sustained or the continuous fever, remittent fever, one that shows significant variation in 24 hours but without return to normal temperature, intermittent fever, an attack of malaria or other fever with recurrent fever episodes separated by times of normal temperature. Then relapsing fever, alternating periods of fever and hyperexia. It's lasting from 5 to 7 days. Saddle type fever and irregular fever. Now let's discuss about the mechanisms of fever. Temperature is ultimately regulated in the hypothalamus. A trigger of the fever, called the pyrogen, causes a release of prostaglandin E2. So the prostaglandin E2 then in turn acts on the hypothalamus, which generates a systemic response back to the rest of the body, causing heat creating effects to match a new temperature level. A pyrogen is a substance that includes fevers. This can be either internal or external to the body. The bacterial substance lipopolysaccharide present in the cell wall of some bacteria, such as the Escherichia coli, is an example of an exogenous pyrogen. Cytokines, especially interleukin-1, are a part of the innate immune system, are produced by phagocytic cells and cause the increase in the thermoregulatory set point in the hypothalamus. Other examples of endogenous pyrogens are interleukin-6 and tumor necrosis factor alpha. This scheme illustrates the normal and the febrile body temperature range. Rash eruption, also very common symptoms in the infectious disease. Dates varies depending on the diseases. The first in the chickenpox, second the scarlet fever, and then smallpox, measles, typhus, and typhoid fever. Then the rash divided into two, exanthemas and enanthemas. The exanthemas also they have the two kinds, the maculopapular rash and the petechias. Maculopapular rash is a flat red area on the skin that is covered with small confined bumps, such as in the measles, and petechia. Also, they may be vesicular-pustular rash and the urticaria. And enanthema that we can find in the mucous membranes. Then, toxemic symptoms may be found in the infectious diseases and the reactions of the mononuclear phagocytic system, such as the hepatosplenomegaly and enlargement of the lymph nodes. Here is the samples of the exanthema, rubella exanthema, that present in the skin as the skin rash, and the measles enanthema. So here you see the terms to classify the infectious diseases that are acute, chronic, subacute, latent, communicable, and contagious. So now let's move on to the infectious diseases. First, we'll start about the viral infections. First, influenza virus infections. The influenza is an acute contagious disease caused by the influenza virus. So the respiratory tract infection but symptoms felt throughout the entire body. It can cause mild to severe illness. At that times can lead to death. The best way to prevent seasonal flu is by getting a seasonal flu vaccination each year. Epidemics occur seasonally with low fatality. More deadly pandemics occur several times each century. Highly changeable virus that can be infect multiple species, including humans, pigs, and birds. The influenza virus, the RNA viruses that make up 3 of the 5 genera of the family Orthomyxoviridae. There are the 3 types: the influenza virus A, influenza virus B, and influenza virus C. The influenza virus A, the type A viruses are the most virulent human pathogens among the 3 influenza types and cause the most severe disease. Type A flu or influenza A viruses are capable of infecting people as well as animals. Wild aquatic birds are the natural host for a large variety of influenza A. The influenza A virus can be subdivided into different serotypes based on the antibody response to these viruses. The serotypes that have been confirmed in humans, ordered by the number of non-human pandemic deaths, are such as the H1N1, which caused Spanish flu in 1918 and the 2009 flu pandemic, H2N2, which caused Asian flu in 1957, H3N3, which caused Hong Kong flu in 1968, H5N1, a current pandemic threat, and etc. The symptoms of the influenza type A has a short incubation period, averaging 2 days. Symptoms include a headache, fever, muscle pain, dry cough. The acute symptoms abate within a week. Cough, fatigue, and generalized weakness may linger. And here you see the symptoms of the influenza. There are three clinical types of the influenza: mild, moderate, and severe. Mild flu, another ways we call the ambulatory flu, the most common type, that localized in the upper respiratory tract, and shown as the acute catarrhal rhinitis, laryngitis, pharyngitis, tracheitis, and the bronchitis. It takes 5-6 days and results by recovery, and signs of intoxication is weak. Moderate flu continues about 1 month and usually results by recovery. Inflammatory processes covers all parts of respiratory system, including the lower respiratory tract, that we call the influenza pneumonia. The most common method for diagnosis of influenza is the detection of cytoplasmic inclusions by test, which are done on nose and throat secretions by swabbing. There are two substances: oxyphilic substances and basophilic substances. Oxyphilic substances are the distraction materials of epithelium, but basophilic substances, the cytoplasmic macrocolonia of viruses. Severe flu has two variants. First, severe general toxemia, this marked type that accompanied with common intoxication, and hemorrhage to the vital centers can lead to death, that we call as the hemorrhagic encephalitis. And second type is accompanied with pulmonary complications, that these lungs we call the large motility influenza lung. This illustration shows the gross pathology of influenza pneumonia. This is the influenza lung, large motility influenza lung, and the histopathology. And here you see the alveoli and the bronchi that filled with the edematous fluid, containing large numbers of the red blood cells and small amounts of lymphocytes and macrophages. And complications of influenza divided into two groups, pulmonary and non-pulmonary. Pulmonary complications are the primary influenza viral pneumonia, secondary bacterial pneumonia, asthma, then chronic obstructive respiratory diseases, bronchitis, cystic fibrosis, exacerbations. Exacerbation of other chronic medical conditions also may complications of influenza. But non-pulmonary complications are the myositis, cardiac complications, toxic shock syndrome, the Guillain-Barré syndrome, transverse myelitis, encephalitis, and Rice syndrome. Now let's continue with the poliomyelitis, or shortly we call the polio. This term taken from the Greek, that means the gray marrow. First described by British physician Michael Underwood in 1799, referring to it as debility of the lower extremities. Poliomyelitis is an acute viral infectious disease which may affect the spinal cord, causing weakness and asymmetric flaccid motor paralysis. Primarily an infection of human alimentary tract, but may infect central nervous system in very small number, less than 1%. The poliovirus is a member of the enterovirus subgroup family Picornaviridae. Enteroviruses are transient inhabitants of the gastrointestinal tract and are stable at acid pH. There are three poliovirus serotypes: P1, P2, and P3. Poliovirus is composed of RNA genome and the protein capsid. The genome is a single-stranded positive sense RNA genome that is about 7,500 nucleotides long. The viral particle is 27 nanometer in diameter, icosahedral symmetry, and non-enveloped. Incubation period of the polio varies between 2 to 12 days, but may last for 1 month. The virus enters through the mouth, and the primary multiplication of the virus occurs at the site of implantation in the pharynx and gastrointestinal tract. The virus is usually present in the throat and in the stool before the onset of illness. 1 week after onset, there is less virus in the throat, but virus continues to be excreted in the stool for several weeks. The virus invades local lymphoid tissue, enters the bloodstream, and then may infect cell of central nervous system. Replication of poliovirus in motoneurons of the anterior horn and brain stem results in the cell destruction and causes the typical manifestation of poliomyelitis. There are some types of the poliomyelitis. Inapparent type is characterized by involvement of pharyngeal and intestinal lymphoid tissues. Visceral or abortive type can be manifested by catarrhal inflammation of respiratory and gastrointestinal tracts. Meningeal type appears as a serious meningitis. These three types are termed non-paralytic types and appear in 99% of all poliomyelitis cases. The most serious type of poliomyelitis is characterized by spinal paralysis is paralytic type. There are 4 stages of paralytic types also: the pre-paralytic stage, paralytic stage, recovery stage, and residual stage. Pre-paralytic stage is associated with a sore throat, cough, raised body temperature, increased pulse rate, and meningeal symptoms. This period lasts 3 to 5 days. Microscopic examination of neurons reveals loss of thyroid matter and thus paleness of nerve cells, necrosis of few neurons. The paralytic stage. The lesions are seen in the motoneurons of basal ganglia, midbrain, medulla, and anterior horns of spinal cord. Many neurons show chromatolysis due to the direct action of the virus. The perivascular infiltration at all stages of neurodegeneration and absorption by the glial neurophagic cells that we call is reparative gliosis. Small hemorrhages with edema are visible in the gray matter. This period lasts from several days to 2-3 weeks. According to localization of pathomorphological change in central nervous system, paralytic type or form is subdivided into 4 clinical forms: spinal, palmar, pointial, and mixed. Spinal polio is most common form characterized by asymmetric paralysis that most often involves the legs. Respiratory paralysis can be fatal due to respiratory insufficiency, atelectasis, circulatory disturbances, which is clinically seen as attacks of dyspnea and choking. Microscopic examination shows signs of neurotrophic atrophy in the diaphragm and intercostal muscles. Bulbar polio occurs in medulla oblongata, where situated at the important vital centers. In this case, the patients have respiratory and swallowing disorders. In the pointial polio, occurs damage of nucleus of 7th pair of cranial nerves, the facial nerves. And mixed form, the bulbospinal, bulbopointial spinal is a combination of bulbar and spinal paralysis. And here you see the illustration of patients with the paralytic type of the polio. Recovery stage may last from 6 months to 1/2 year. The glial scars form at the site of neurophagic nodules and small size form in small softening foci in the brain. Due to this morphological change, impaired functions are gradually restored. And the residual stage is characterized by the complications such as the paralysis, atrophy of skeletal muscles, the formation and osteoporosis of bones, and contracture of joints that results by disability. And outcomes of the poliomyelitis may be asymptomatic, 90-95%, minor illness, aseptic meningitis, paralytic poliomyelitis that we discussed about the spinal, vulvospinal, and vulvar polio cases, types. Measles, or another name we call the rubeola or the morbilli, is an acute, highly contagious viral disease caused by measles virus. Symptoms usually develop 10-12 days after exposure to an infected person and last 7 to 10 days. Initial symptoms typically include fever, often greater than 90 degrees, cough, runny nose, and inflamed eyes. Usually involves children aged from 6 months to 5 years. Measles infection was distinguished from smallpox as early as the 9th century by an Arab physician by the name of Abu Bakr Razi, the doctor of Baghdad. Measles morbillivirus, formerly called measles virus, is a single-strand, negative sense, enveloped, non-segmented RNA virus of the genus morbillivirus within the family Paramyxoviridae. Mechanism of spread and pathogenesis of the measles. After the inoculation of respiratory tract, they occur the local replication in the respiratory tract that continue the lymphatic spread and results by the viremia, and the wide disseminated that results by the conjunctive respiratory tract, urinary tract, small blood vessels, lymphatic system, and central nervous system. Then virus infected cells that interact with the immune T cells results by the development of the rash. So the clinical findings of the measles. Measles has 4 clinical stages: incubation stage, prodromal stage, eruption stage, and recovery or convalescent stage. Incubation stage lasts approximately 10 days. Prodromal stage is characterized by symptoms known as clinical trial, such as conjunctivitis, rhinitis, and cough. The next day, whitish papules appear on the oral mucosa at the level of low small premolar, known as the complex pores. Catarrhal or catarrhal purulent exudate inflammation develops in the mucosa of nose, pharynx, larynx, trachea, bronchi, and conjunctiva. Here's the typical clinical presentation of the complex pores in the oral mucosa. Then the rash or eruption stage. The time is the 3 to 5 days after fever, but the 4th day is most common. The shape of the rash is the maculopapilla or exanthema, and how they start, the segments of the appearance of the rash. They first start behind the ear, then along the hairline, then face, neck, chest, back, abdomen, limbs, hand, and feet. The inflammatory stenosis, edema of the larynx with shortness of breath leads to pseudocrue. Epithelium of respiratory tract undergo to squamous metaplasia. Inflammation may extend to bronchioles and alveolar septa with development of interstitial pneumonia. And this pneumonia is called giant cell measles pneumonia due to presence of a large number of giant multinucleated wort and Finkel-based cells. And convalescent stage is characterized by bronze staining and fine briny desquamation of previous exanthema sites. And here you see the illustrations about the clinical finds of measles. And the microscopic illustration of the wort and Finkel-based cells in the giant cell pneumonia. The complication of the measles. There are the pulmonary complications, the purulent necrotic bronchitis and peribronchitis, bronchopneumonia, atelectasis, emphysema, lung gangrene, and pleural empyema. Pseudotuberculous measles pneumonia, neural complications such as the subacute sclerosing panencephalitis and stomatitis, the necrotic destruction of soft tissue of cheek referred as noma, the watery cancer. Now let's move on HIV infection or AIDS, the acquired immune deficiency syndrome. It was first identified in 1981 in a small group of gray men in the San Francisco area who presented with unusual opportunistic infections. In 1983, the human immunodeficiency virus responsible for AIDS was first isolated. According to the World Health Organization, over 37.9 million people are living with HIV infections. Women are increasingly at risk for HIV infection. Currently, and 47% of adults infected worldwide with HIV are women. HIV belongs to a class of viruses called retroviruses. An HIV virus particle is spherical and has a diameter of about 1 to 10,000 millimeter. Like other viruses, HIV does not have a cell wall or a nucleus. The basic structure of the virus is as follows. First, the viral envelope, then HIV matrix proteins, and the viral core. And here you see the schematic structure of the HIV. The transmission of the HIV infections. For flus, if infected, can transmit HIV, that the blood, semen, vaginal secretions, and breast milk. For flu that can transmit HIV, saliva, urine, sweat, and tears. HIV infects a limited number of cell types in the body, including a subset of lymphocytes called CD4 positive T helper cells and macrophages. Through the action of reverse transcriptase, HIV produces DNA from this viral RNA. Transcription is often poor, leading to mutations, and some such mutations make HIV resistant to antiviral drugs. The viral DNA enters the nucleus of the cell and is incorporated into the host cell's DNA, where it is transcribed into more viral RNA. If the host cell reproduces, it duplicates the HIV DNA along with its own and passes it on to the daughter cells. Thus, if activated, the host cell carries this information and, if activated, replicates the virus. Viral enzymes, protease, arrange the structural components and RNA into viral particles that move out to the periphery of the host cell, where the virus builds and emerges from the host cell. Thus, the virus is now free to travel and infect other cells. HIV replication may lead to cell death or it may become latent. And here you see the very fine illustration of the HIV replication cycle. The clinical findings of HIV infections. AIDS develops in 4 periods or stages: latent period, generalized lymphadenopathy, pre-AIDS, and AIDS periods. Latent period, the disease begins with HIV infections. HIV-infected patients may have no symptoms for 10 years or longer. They can still transmit the infection to others. Blood analysis reveals HIV and anti-HIV antibodies. Generalized lymphadenopathy lasts about 3 to 5 years. Different groups of lymph nodes become swollen. Chronic lymphadenopathy syndrome. Pre-AIDS stage, fever, sweating, particularly at night, lymphadenopathy, chills, weight loss, flu-like symptoms, and diarrhea include. And final stage, AIDS stage, lasts about 2 years, and the T helpers count drops below 200 cells per 1 cubic millimeter. In peripheral blood, the anti-HIV antibodies almost have not been revealed, but HIV are in a large amount. Due to complete failure of the immune system, the characteristic opportunistic infections, malignant tumors, and cachexia develop in patients. and from the central nervous system develops a progressive multifocal leukoencephalopathy. Most frequent opportunistic infections is pneumocystic pneumonia, and most common malignant tumors are the Kaposi sarcoma and Burkitt's lymphoma. And clinical variants of AIDS. This is first the pulmonary form in 80%, cerebral form, GI form or gastrointestinal form, and fever of unknown etiology. Now we moved on the another type of the infectious diseases and rickettsia. Are the parasitic bacteria, obligate intracellular parasites, bigger than virus, smaller than bacteria, carried by host animals and invade the human mononuclear cells, neutrophils, blood cells, and endothelium. Epidemic typhus is the most frequent rickettsioses. Another name is the Laws-borne typhus. This anthropootic infections transmitted by Pediculus humanus corporis, the human body louse. The heat lice does not transmit these infections. Pathogen of this disease is Rickettsia provizii. Infection acquired by feeding of infected person. Excrete Rickettsia provizii infectis at time of feeding. Lice die within 2 weeks, and louse feces rubbed into bite or superficial abrasions, that inhalation of feces. There are pathogenesis, here you see, of the epidemic typhus, that they multiply in the endothelial cells of small blood cells, that results development of the vasculitis, and development of vasculitis results by the appearance of the rash, the skin rash, the disseminated intravascular coagulation syndrome and vascular occlusion, then the swollen and necrotic of the tissues and thrombosis of the vessels. And clinical symptoms. The incubation period varies between 7 to 14 days, and high fever, chills, headache, cough, myalgia, that they may lead to coma. And macular eruption, the 5 to 6 days after onset, initially on upper tract, spread to entire body, except face, palms, and soles of feet. There are subclinical, mild, moderate, severe, and fulminant clinical forms or types. And the types of vasculitis during the epidemic typhus are the endothrombovaculitis, proliferative vasculitis, necrotic vasculitis, and mixed vasculitis. The clinical findings of epidemic typhus. The epidemic typhus granuloma forms during the disease is known as the Popov's granuloma. From the central nervous system develops the meningoencephalitis, delirium, and hallucinations that we call the status typhosus. From the heart develops the proliferative interstitial myocarditis that results with the heart failure, and 70% patients dies. And complications of the epidemic typhus are the myocarditis, heart failure, cerebral involvement, thrombophlebitis, renal failure, secondary pulmonary inflammation foci, gangrene with loss of fingers and toes, and etc. What makes the Brill-Zinsser disease? The rickettsia can remain latent and reactivate months or years later with symptoms similar to or even identical to the original attack of typhus, including a maculopapular rash. This disease we call the Brill-Zinsser disease. Mild illness and low mortality rate, and rash is rare in these diseases. Next disease, next group are the bacterial airborne infections. Let's start from the diphtheria. Is airborne infection caused by Corynebacterium diphtheria bacteria. Very contagious and potential life-threatening bacterial diseases. Localized infection disease which usually attacks the upper respiratory tract. And diphtheria bacilli colonize and grow on mucous membrane that start to produce toxin, which is then absorbed into the mucous membranes and even spread by the bloodstream. Diphtheria exotoxin causes all clinical and morphological manifestations as cytopathic, vasoparalytic, and neuropathic change. Local toxigenic effect include the illicit inflammatory response and necrosis of the pharyngeal mucosa cells, formation of pseudomembrane that composed of bacterial lymphocytes, plasma cells, fibrin, and dead cells, causing respiratory obstruction, and systemic toxigenic effects, necrosis in cardiac muscle, liver, kidneys, adrenals, and nerves. There are two types of the diphtheria, Croupo's types and the diphtheritic types. In the Croupo's type develop the thin fibrinous pseudomembrane, and the diphtheritic type the thick fibrinous pseudomembrane. According to localization, there are two types of the diphtheria, pharyngeal or the laryngeal or upper respiratory tract form. Incubation period include 2 to 10 days, and there are typical and atypical clinical types. The typical types have three periods, the mild, three types, the mild, moderate, and severe, and atypical types include the catarrhal, hypotoxic or fulminant, and hemorrhagic. The pharyngeal diphtheria is insidious onset. The exudate spread within 2 to 3 days over the mucosa and may form adherent with submucosal vessels, the diphtheritic pseudomembrane. This causes bleeding when the pseudomembrane is forcibly removed. Local change in cervical region, regional lymph nodes, are the hyperplasia, edema, hyperemia, hemorrhage, and necrosis. General change in heart, toxic interstitial myocarditis that results with the acute heart failure, and early heart cardiac paralysis occurs at the beginning of the second week. In nervous system, diphtheritic neuropathy, characterized by the parenchymatous neuritis, paralysis of nerves as well as cardiac nerves that results by the late heart paralysis. In kidneys, develop the necrotic nephrosis that results by the acute renal failure. In adrenals, diapedesic hemorrhage in medulla, necrosis both in cortex and medulla that results in destroying of adrenal synthesis that results in collapse in patients. Here you see the illustration of the pseudomembrane in the pharyngeal diphtheria. And laryngeal or the upper respiratory tract diphtheria can be either an extension of the pharyngeal form or the only site involved. Symptoms include the mild fever, dyspnea, hoarseness, and the barking cough. Pseudomembrane can lead to airway obstruction, coma, and death. Complications are the asphyxia, then suppurative perichondritis, otitis media, and mediastinitis. Next disease is scarlet fever or scarlatina. Is acute respiratory infectious disease of childhood. Commonly affects children 3 to 7 years old. Pathogen is hemolytic Streptococcus B group A. The reservoir is the infected person. That these bacteria are spread by direct contact with infected person or by droplets exhaled by an infected person. Incubation period 5 to 6 days. And there are the types of the scarlet fever. Mild type, moderate type, severe type. Severe type also has some subtypes, the severe toxic type, severe septic type, and severe toxicoseptic type. Clinical features are fever, pharyngitis, general diffuse fresh, red eruption, and abbrevious desquamation. In this scheme are the pathogenesis and clinical findings of the scarlet fever that, as we said, that affect the children between the 5 to 15 years old, and here we see the adhesions including the lipoteichoic acid and M protein with the group A streptococci cell wall facilitates regional adherence to pharyngeal epithelial cells, and the group A streptococci releases the streptococcal pyogenic endotoxin. Then A, B, and C groups and the streptococcal superantigen. And they result the stimulation of the T cells and mononuclear cells that results with the general inflammatory response, white strawberry tongue, and the coating slough of after 2-3 days, and the development of the red strawberry tongue. I will show you in the next slides. And these toxins that enter systemic circulation results the delayed type hypersensitivity response, and they result the development of the scarlatina form rash. To the first stage post-pharyngitis, pustules lines, then 1 to 2 days post-pharyngitis the rash appears on the upper trunk and axilla. Between the 2-4 days, the rash spread to remainder of body, sparring face, palms, and soles. And the 7 to 10 days, the rash phase results by the desquamation. Here you see the perioral pallor, we call the fillet of symptoms, and red strawberry tongue. Also, here you see the generalized rash, the pustule lines here and here, then also the fillet of symptom or fillet of mask, and desquamation of the palm and soles as well. Next disease is meningococcal infections. Is acute infectious disease. Although may occur in any age group, it usually affects children. This is typical anthroponosis. The reservoir of infection is an infected human. Pathogen is Neisseria meningitis diplococcus. Meningitis diplococcus. Pathogenesis, colonization and penetration of nasopharyngeal mucosal membranes by bacteria, survival of bacteria in blood and transportation via circulation, invasion of the central nervous system, multiplication in subarachnoid space, increased blood-brain barrier, and resulting in purulent meningitis. So the meningococcemia in immune deficiency patients. Clinical classifications are the localized form, we call acute nasopharyngitis, generalized form, meningococcemia, meningitis, and rare form, endocarditis, arthritis, pneumonia, iridocyclitis. And here we see the clinical manifestations and symptoms of the meningitis. There are prodromal period that continue to the septic period and meningitis period and the recovery period. And in the septic period, there's an abrupt onset, chills, high fever, headache, petechias, purpuras, and splenomegaly. And the meningitic period, characterized by the intracranial pressure, headache, vomiting, restlessness, stiff neck, curling, and Brudzinski symptoms positive. And in the recovery or the convalescent period, they gradually disappears and recovers to normal conditions. Here you see the petechia in the skin in meningococcal meningitis. And also the clinical presentation of the patient with the meningococcemia. And complication of the meningococcal infection. They disseminated intravascular coagulation and thrombosis, toxic allergic shock, cirrhosis or purulent arthritis, suppurative pericarditis, ecchymosis or the exanthemas, and bilateral hemorrhagic adrenal necrosis that results with acute hypocorticism with electrolyte imbalance and spontaneous hypoglycemia that we call the water hose Friderichsen syndrome. Here you see the gross pathology of the water hose Friderichsen syndrome and the histopathology. Now let me move on the next group of the infectious diseases, bacterial intestinal infections. First, we will discuss about the typhoid or typhoid fever. Typhoid fever is a bacterial infection due to Salmonella typhi that causes symptoms which may vary from mild to severe and usually begin 6 to 30 days after exposure. Disease is transmitted by the ingestions of food or water contaminated with the feces of an infected person. The organism is a gram-negative, short bacillus that is motile due to its peritoneal flagella. The name of typhoid comes from the neuropsychiatric symptoms common to typhoid and typhus. From Greek, it means the stupor. The pathogenesis of the typhoid fever. That first, the ingest contaminated food. Ingested bacilli invade small intestinal mucosa, taken up by macrophage and transported to regional lymph node. Salmonella typhi multiply in the intestinal lymphoid tissue, intact with enterocytes and the heme cells, the ileal pair pairs, during the 1 to 3 week or incubation period that results with the diarrhea. End of incubation period, bacilli enter bloodstream. That starts the bacteremia phase. And bacteria invade the gallbladder, biliary system, and lymphatic tissue of the bowel and multiply in high number. Then pass into the intestinal tract that present in the stool. The clinical findings of typhoid fever. Often there is a gradual onset of a high fever over several days. Weakness, abdominal pain, constipation, and headaches also commonly occurs. Diarrhea is uncommon and vomiting is not usually severe. Some people develop a skin rash with rose-colored spots. In severe cases, there may be confusion. Without treatment, symptoms may last weeks or months. Other people may carry the bacterium without being affected. However, they are still able to spread the disease to others. Typhoid fever is a type of enteric fever along with paratyphoid fever. There are 5 stages of diseases. First, we call the medullary swelling, infiltrating of pair patched by inflammatory cells, typhoid cells, and here it forms the typhomas, the granulomas. Because this is a typhoid fever, also the granulomatous diseases. Typhomas accumulate in lymphoid follicles, which get the medullary appearance. They resemble the structure of the brain gyrus. Then necrotic lymphoid follicles absorb bile and turn in brown. Third stage is ulceration, also as called the clear wounds. The necrotic lymphoid follicles, due to intestinal peristaltics, are partially ruptured and poured into the intestinal lumen, and wounds form in their place. Next stage, the wall of the wounds is clean. At the bottom of the wounds appear intestinal musculature and sometimes the serous layer. And the final stage in the healing, not very rough scars appear on the mucous membrane. The common morphological change in typhoid fever we can classify it in the specific change and non-specific change. Specific change present into 2 clinical signs with the typhoid rash and typhoid granulomas. But non-specific morphological change are the hyperplasia of lymphoid tissues and degenerative change of organs. The rashes in the typhoid fever. They may present with the rash, rose spots, 2 to 4 mm in diameter, raised, discrete, irregular blanching, pink macules found in front of chest. Appears in crops of up to a dozen at a time. Fade after 3 to 4 days. And here, this is the histopathology of typhoid granuloma. And here you see the ileal mucosa showing non-caseating granuloma within the lamina propria, and also the photomicrograph of mesenteric lymph node that shows the granuloma with multinucleated giant cells. And there are 2 groups of the typhoid fever complications. First, intestinal complications and extraintestinal complications. Intestinal complications are the bleeding, perforation, and peritonitis. Extraintestinal complications are the splenomegaly, rupture of the spleen, Zenker necrosis of muscles, pneumonia, sepsis, toxic shock, osteomyelitis, otitis, pyelonephritis, meningitis, and stomatitis. And here you see the clinical presentation of the perforations of the intestinal wall during the typhoid fever. Now we'll discuss about the cholera. Every year, 3 to 5 million people around the world are infected with cholera, and 100,000 and 200,000 people die from the infectious diseases. The word cholera is from Greek meaning the bile. Cholera likely has its origin in the Indian subcontinent. The disease first spread by trade routes by land and sea to Russia in 1827. Then through technological advancements to the rest of Europe, and from Europe to North America and the rest of the world. 7 cholera pandemics have occurred in the past 200 years. Since that time, untold millions have contracted and died from this preventable infectious disease. Epidemiology of the cholera. The pathogen is Vibrio cholera, short curved gram-negative bacilli. And you see here the microscope of the cholera Vibrio. It is highly contagious infection. Humans are the reservoir of the pathogen. The pathogen is contaminated or untreated drinking water and food, and multiplies in the lumen of the small intestine, the duodenum. Antitoxic immunity is acquired after recovery. The pathogenesis of the cholera. The Vibrio cholera accumulates in stomach, produce toxins, that these toxins will bind to the G protein coupled receptors, that inactivation of the GTPase and G protein stuck in on position, that increase the cyclic AMP, and this results the activation of the ion channels, and the sodium chloride influx into intestinal lumen to drag water into lumen, that lead to watery diarrhea. And here you see the mechanism of action of cholera toxin. Now let's discuss about the clinical presentation of the cholera. The cholera-related diarrhea comes on suddenly and can quickly cause dangerous fluid loss, as much as a quart an hour. Diarrhea due to the cholera often has a pale, milky appearance that resembles water in which rice has been rinsed. Vomiting occurs especially in the early stage of cholera and can last for hours. Dehydration can develop within hours after cholera symptoms start and range from mild to severe. A loss of 10% or more of body weight indicates severe dehydration. Muscle cramps result from the rapid loss of salts such as sodium chloride and potassium. Shock is one of the most serious complications of dehydration. It occurs when low blood volume causes a drop in blood pressure and a drop in the amount of oxygen in body. If untreated, severe hypovolemic shock can cause death in minutes. Here you see the tables about the clinical presentation of cholera. Here you see the assessment of the patients with diarrhea for dehydration, that divided into the 3 degrees, the none, some dehydration, and severe dehydration more than 10%, and the clinical features. And according to the proportion of lost fluid, the dehydration has 4 degrees. First degree 1 to 3%, second degree 4 to 6%, mild degree 8 to 9%, and more than 9% 4 degree. And a clinical stage of cholera. There are 3 stages. Stage of choleric enteritis, stage of choleric gastroenteritis, and algid stage. This is the lowering body temperature between the 35 to 34 degree of Celsius. And clinical signs and symptoms of dehydration. They include the irritability, fatigue, sunken eyes, dry mouth, extreme third, dry and shriveled skin that's slow to bounce back when pinched into a fold, little or no urinating, low blood pressure, and irregular heartbeat. And autopsy findings of cholera patients are the corpse razor, gladiator's pose, hypocatic face, glassy eyes, choleric falls, washerwoman's hands, white bile, and rice water with fishy odor. It is a adult cholera patients with sunken eyes and washerwoman's hand signs. The complication of the cholera divided into the specific and non-specific. Specific complications are the choleric typhoid, that characterized by the diphtheritic colitis, typhoid exanthemas, and septic change, and post-choleric uremia due to the multiple necrosis or infections of renal cortex. And non-specific complications are the uremia, acute renal failure, coma, shock, and secondary infections such as the pneumonia, abscesses, and sepsis. And our final disease is dysentery. Dysentery is acute bacterial infections affecting the distal part of large intestine, as well as rectum and sigmoid colon. It is typical anthroponosis. Pathogens Shigella, but the Shigella after the Shigella also the Escherichia coli, Salmonella, Entamoeba, Campylobacter, and Yersinia enterocolitica also can be pathogens of the dysentery. Shigella is a gram-negative, non-motile bacillus belonging to the Enterobacteriaceae family. There are 4 species of the Shigella: Shigella dysenteria, Shigella flexneri, Shigella boydii, and the Shigella zonne, that designs as a serogroups of A, B, C, and respectively. On a global scale, of the estimated 165 million Shigella diarrheal episodes estimated to occur each year, 99% occurs in developing countries, mainly in children. Infants, non-breastfed children, children recovering from measles, malnourished children, and adults older than 15 years have more severe illness and a greater risk of death. Transmission occurs via the fecal-oral route, person-to-person contact, household flies, infected water, and inanimate objects. Incubation period is average 2 to 3 days. Bacterial cells preferentially attach to and invade into M cells in pairs of small intestine. M cells typically transport foreign antigens from the intestine to underlying macrophage. Shigella can leave the phagocytic vacuole, replicate in the cytoplasm, and secrete the toxins. Exatoxin, or another name is shigatoxin, is neurotoxic, cytotoxic, and enterotoxic, encoded by chromosomal genes. Endotoxic effect of exatoxin. The shigatoxin adheres to small intestine receptors, blocks absorption of electrolytes, glucose, and amino acids from the intestinal lumen. Cytotoxic effect. B subunit of shigatoxin binds host cells glycolipids in large intestines, inactivate the C-ribosomal subunit, inhibit protein synthesis, causing cell death, microvascular damage to the intestine, and hemorrhage. Neurotoxic effect include the fever, abdominal cramping, and they have the vasoparalytic effect. The clinical presentation of the dysentery. There are 3 types: the acute dysentery, chronic dysentery, and subclinical dysentery. Acute dysentery has 3 subtypes also, with the development of colitis, the typical dysentery with colitic syndrome and toxemia, then gastroenterocolitis, the dehydration with various degrees, and gastroenteritis occurs without colitis. Then chronic dysentery that continue more than 2 months, has also mild, moderate, and severe types phases. There are 2 types: the chronic delayed type, characterized by the diarrhea long time and repeated, and chronic obscure type, This acute history in 1 year, no symptoms, stool culture positive or sigmoidoscopy. And acute attack time, the same as common acute dysentery. But subclinical dysentery will characterize the bacterial caries condition. There are two morphological changes in the dysentery, local change and general change. Local change usually develop in the rectum and sigmoid as the inflammatory process. First, catarrhal colitis, that characterized by the colitic syndrome and toxemia, and antibiotic therapy may lead to recovery at this stage. Then fibrinous diphtheritic colitis, and also the formation of the diphtheritic pseudomembrane that lasts 5 to 10 days, and ulcerative colitis, the multiple hemorrhages and possible perforation that develops in 10 to 12 days. And finally, recovery stage lasts 2 weeks, and diffuse sclerosing can result in cirrhosis, that narrowing and deformation of intestine. And general change are the two groups. The first, hyperplasia of lymphoid tissue, and degenerative and necrotic change in organs such as the heart, liver, and kidneys. And the complication of the dysentery divided into intestinal and extraintestinal groups. The intestinal complications are the phlegmona of intestines, bleeding, perforation, peritonitis, paraproctitis, toxic dilation of intestine, and cirrhosis of large intestine. But extraintestinal include the toxic and dehydration shock, tubular interstitial nephritis, pyelitis, pyelonephritis, pneumonia, otitis, polyphlebitic abscess of liver, and secondary amyloidosis. And we finished our lecture. Thank you for attention.